Yeah. Good evening, everybody. So we are back again with the next episode of Amasi CME, and we have a very exciting program lined up today. We have an overseas guest who's going to give us a very interesting talk on an enlightening talk on a very current and uh, intriguing problem in which many a times we, even as experienced colorectal surgeons, we face dilemmas exactly what should be the next step. So I hope most of our doubts get cleared up at the end of this talk. And I'll request all the viewers to please post and be interactive. Please post your queries in the chat box. Our moderators will convey your queries at the end of the talk to the speakers and the moderators themselves, and they'll discuss the things out among themselves and clarify all those doubts for you. So I'll hand over now to Dr. O.V. Sudhir, who is our zonal vice president from the south. Sudhir sir, over to you.
Thank you, Dr. Jani. Good evening, everyone, and welcome for the next MRC CME online program. This time we have a very interesting topic, the recurrent rectal cancer, which is really a challenging topic, and it's a complex treatment problem also. So the rectal cancer is one of the most common cancer which can occur. The multimodality treatment has reduced the local recurrence rate and also the distant recurrence rate in survival. But and also with the introduction of the TME, the local recurrence rate has come down from around 30% to 10%, and it has still further has come down to 5%, the local recurrence rate, with the introduction of neoadjuvant chemoradiotherapy. The distal metastasis still remains high, maybe up to 20-25%. And most of these recurrences are asymptomatic and may need a close follow-up to detect this with the patients, especially the distal recurrences. Even though local recurrences are so rare, it's a very significant problem because of the morbidity associated with the recurrent rectal cancer, local recurrence cancer, and the complexity associated with the treatment of a local recurrent rectal cancer. To discuss about this topic further, we have an eminent speaker today, Dr. Athur Harikrishnan from Sheffield University Hospitals, Ireland. Dr. Raj Pandyan, one of our moderators, will be introducing him further. So before that, I will introduce the moderators of this session. We have Dr. Deboshi Sharma, who is the Director and Professor of Surgery, Atal Bihari Vajpayee Institute of Medical Sciences and RML Hospitals, New Delhi. He is one of the strong pillars of the Association of Minimal Access Surgeons of India. He is our former vice president, former secretary, and also is our current vice president. About Dr. Raj Pandyan, who is the other co-moderator of this session. Dr. Raj Pandyan is the academic director and unit head, senior consultant gastroenterologist, Department of Surgical Gastroenterology, GA Oncology, Robotic and Minimal Access Surgery, GEM Hospital Research Center, Coimbatore. I would request all of the delegates to keep their mobile in mute, and also you have to please have interaction with us. You can post your questions in the chat box. We will be discussing all of them after the topic. With this, I hand over the platform to the moderators, Dr. Deboshi Sharma and Dr. Raj Pandyan. Thank you.
Thank you, Dr. Sudhir, for the nice introduction. So now I would like to introduce the speaker, who is my friend, Dr. Athur Harikrishnan. He is a senior consultant colorectal surgeon from Sheffield, UK. His clinical interest includes robotic and laparoscopic surgery for both benign and malignant conditions, and including transanal surgery like TAMIs and IBD and colonoscopy. He also offers advanced laparoscopic surgical technique in like SILS, that is single port laparoscopic surgery. He graduated from Madras Medical College in 1992. He completed his basic surgical training and earned a MS degree in India. In 1997, he obtained 2 fellowship FRCS from Royal College of Surgeons of Edinburgh as well as Glasgow. His further surgical training occurred in South Wales and East Anglia. He undertook a research project on colorectal cytogenetics at Swansea University, where he was awarded the MPhil degree in 2006. He achieved an intercollege FRCS in 2009 and has been practicing as a colorectal and general surgical consultant since 2010. Until recently, Mr. Harikrishnan was a training program director for general surgery in health education, Yorkshire. He is a honorary clinical senior lecturer at Edge Hill and Sheffield University. Additionally, he is the course director for several surgical skill courses. He is part of the technical faculty at the University of East Anglia, Edge Hill University, and the University of Edinburgh. He serves as the academic director of the Sheffield Academy for Surgical Skills and Simulation. He is the president-elect of the Association of Coloproctology of Great Britain and Ireland. Now, I request Dr. Athur Harikrishnan to take over the stage and talk his topic.
Thank you very much, Dr. Rajapandian. And it is my privilege and it is my gratitude. Special thanks to MRC organizing committee for giving me this privilege to speak to this in the CME and also participate in your educational program. I'm really privileged. Thank you. So we're going to speak about recurrent rectal cancer. Recurrent rectal cancer, obviously, as the name suggests, the patient should have had primary surgery for rectal cancer before. So when we define rectal cancer, the recurrent rectal cancer,
we are not seeing the slides. We are not seeing the slides.
Please share your presentation again. I think when they started the program, they shut it off.
Okay, I'll do that. I'll do it. But the audio is clear, isn't it?
Audio is absolutely clear. Absolutely clear.
So is it back on now?
Yes, we got it.
Yeah. Perfect. Perfect.
Thank you very much. So what I wanted to start off with is by defining recurrent rectal cancer. So we define recurrent rectal cancer as once they had their primary surgery for rectal cancer, and they can get a recurrence. They can get a recurrence locally within the lesser pelvis, or they can get a distant recurrence or combination of both. So when the patients had treatment for rectal cancer but not had surgery, like total neoadjuvant therapy, long-course chemoradiotherapy, these days we get complete clinical response. So when these patients have recurrence of the tumor, it is technically defined as regrowth of rectal cancer. It is not technically a recurrence because we are not quite sure whether it was completely cleared in the first instance. So the entire talk is going to deal with local recurrence within the pelvis of rectal cancer once they have had some form of primary surgery in the treatment, with or without neoadjuvant therapy. Rectal cancer can occur after a total mesorectal excision or a partial mesorectal excision. When I say partial mesorectal excision, is that when we do an upper rectal cancer, at least in our practice, we do not go right through to the pelvic floor to remove every perceptible mesorectal package. We divide the rectum, mid-rectum, so there it is technically a partial mesorectal excision. You can have recurrent rectal cancer after local excision. So we do a lot of patients for transanal microscopic, endoscopic microsurgery, TAMIS procedure, even transanal excision for T1 tumors. And when these recur, they are technically a local recurrence. So many patients have previous radiotherapy and chemotherapy. And if they didn't have it, they fall into a category of recurrent rectal cancers which have not had neoadjuvant therapy. So we call them radiation naive. So that the reason to brand them like radiation naive is because some of their treatment strategies are different if they had previous radiation and chemotherapy. So as we heard previously, the advancement in staging, multidisciplinary team
Again frozen.
recurrence of rectal cancer has reduced massively from 30% to around 6 to 12%. It depends on the tumor biology. It depends on patient-dependent characteristics and also on the treatment offered in the first instance. Let's see at some of these factors because these are really important when it comes to designing the treatment strategies once they get a recurrence. It is well known that a narrow male pelvis in a person who's overweight carries a much higher risk of rectal cancer because of the completeness of the first procedure can be compromised somewhere, either in the circumferential resection margin or distally in the distal clearance margin or lymph nodal metastasis, which wasn't identified. Patients with immunodeficiency disorders, we have a huge cohort of patients who are transplant patients who are immunosuppressed, who have a higher degree of recurrence if they had a primary treatment rectal cancer because they're surviving that much longer now. So we face them in a situation where they have immunosuppressed at the same time have a recurrent rectal cancer. Apparently, I have not faced this myself, but advanced stage is a fact. In fact, it is very clear. It's very clear that the caseload the individual surgeon or the unit undertakes carries a direct relationship to the incidence of recurrent rectal cancer in the unit. So it's very clear that the more cases you do, the more precise you get in your dissection, the better is your outcome, your personal outcome, and your unit's outcome. So less is the incidence of rectal cancer resections. The nominal resections per year one has to undertake is about 10 to 12 resections a year. What doesn't sound very high, but if any surgeon or a unit is undertaking less than 10 to 12 rectal resections per year, they probably have to rethink whether they have to continue doing it or refer to a neighboring center with a higher volume for the benefit of the patient. Or these days, joint operating is also very common. So we can go and operate with another experienced surgeon. So the transanal mesorectal excision has, as we have heard, definitely reduced the incidence of local recurrence from our 30% to 3% now, with purely because of the surgical technique. And in the post-surgical histology, post-operative histology, if the patient is not R0, microscopically, high chance that they fall into a category if they get a rectal cancer recurrence. So if they have an R1 resection, there's a 30 to 50% chance. And if they have R2 resection, which means macroscopically, if you're left piece behind, then there is undoubtedly there's going to be some form of recurrence at some point. Some of the tumor factors which contribute to local recurrence are poor differentiation, mucinous signet ring type tumors, presence of lymphovascular and perineural invasion, and the response to neoadjuvant chemoradiotherapy. If the tumor regression grade is 1 to 2 in the scheme of 1 to 2, there's less recurrence. If they've not responded that well, which means it's a high-grade non-responsive tumor, then they get more recurrence. And also after local recurrence, we're getting a surge of local operations now performed for early rectal cancer. If any of the tumors removed locally are more than 3 centimeters and occupy more than 30% of the circumference, every 6 months and yearly after that. They get CEA every 3 months. endoscopy every 6 months, 12 months, and CT scan every 2 years. It depends on the unit. So the recurrences are picked up during surveillance, even before the patient gets symptomatic. So one should be very careful about this. So if you're doing rectal cancer surgery, you must have or join a program to offer surveillance in the post-operative period. And Hanslow's subgroup these in depending on the presence of symptoms in S0, 1, and 2. S0 is they are asymptomatic, picked up on surveillance, and the recurrent rectal cancer patients who present with pain, without pain, are in the S1 category at about 20-25%. And if they have pain, half of them have pain in the advanced stages. And if they have pain which is not responding to treatment, poor prognosis, which means that is a nerve involvement, either the main trunk or one of the branches of the pelvic nerves involved. Undoubtedly, during the surveillance, just a rectal examination will pick up about a fifth of the rectal cancers. So even before any staging or scans are done. As we all know, early detection of rectal cancer translates to a better prognosis. About 60% of the rectal cancers are picked up in the first 2 years after having primary treatment for rectal cancer. And by third year, 80% present. And by the fourth year, 90% of the recurrence is present. So the recurrences detected after 4 to 5 years is very uncommon. It's very less. That is why our surveillance program stop at 5 years. There's no surveillance offered after 5 years. But they can undergo the National Bowel Cancer Screening Program out of the post-cancer surveillance program. Let's talk about a little bit about the staging and classification of recurrent rectal cancer. We know the classification, TNM classification of primary rectal cancer, according to the version 8. So it is very clear. But when it comes to staging of recurrent rectal cancer, the original TNM staging is not valid anymore. And because of the variability in diagnosis and procedures in different units, I've just lined up. There are some 10 different stagings already. Which one you follow depends on what you're comfortable with. So the individual member can pick up whatever they want to, whichever type of staging they want to follow. But if they follow the same one, the easiest classification because that's how the anatomy is designed. And the inferior compartments are divided into infralateral and anterior urogenital triangle, subdivided because of the exclusivity of organs in that space. So as you can see from this, I don't know whether you can see the cursor. I'm moving the cursor. But you can see the central compartment is where the neorectum is, where the anastomosis is, and where the commonest site of recurrence happens. And then we have the posterior compartment, which is into the presacral fascia and the bone. And this compartment recurrences are really difficult to treat. And then we get the anterior compartment divided into above the peritoneal reflection and below the peritoneal reflection. And these involve different urogenital organs depending on the sex, male or female patient. So I find this classification really simple to follow. And one wants to start off using one, I would recommend this one. So the central recurrences are the commonest one which we face in the neorectum, the rectal remnant, or the postoperative anastomotic colon, which is there, where you get the recurrences, then followed by the lateral compartments, and then the posterior compartment and the rest. So how are we going to manage this? We will go into the investigations in a bit, but we have to understand that when a person gets recurrent rectal cancer, surgery is the primary therapeutic choice to get a cure. It is not easy to get a cure with neoadjuvant therapy for rectal cancer because of the way surgery is the primary therapeutic. And the multidisciplinary team here for recurrent rectal cancer is 10 times bigger than primary rectal cancer. So we have orthopedic surgeons, plastic surgeons, we have urologists, we have every perceptible physiotherapist, pelvic floor physiotherapist, nutritionists, intensive care specialists, every perceptible individual, including intestinal failure consultants, to manage it. So it is 10 times bigger. I've not gone into each one because we're going to deal with the surgery side of the things. So once we have detected the patient has a rectal cancer recurrence, one of the adjuncts which helps surgery achieve a cure is neoadjuvant therapy, either for the first time or repeat once, because they might have had previous neoadjuvant therapy for their primary rectal cancer. And a multi-specialty surgical approach may be required. Definitely need the gynecologists, urologists, orthopedic surgeons to complete the surgical procedure. Once we've done the surgical procedure, the patient goes through several weeks of postoperative rehabilitation, depending on the magnitude of surgery one is done. And if a curative surgical approach is not fulfilled or it is not practically possible, that's not the end of the story. The option to have palliative treatment to give them the comfort and the quality of life for the next few months they're going to live is really important. This is a really upcoming field. We have a huge palliative care department, and I learned that the palliative care treatment specialists are now available in the Indian setup as well. So once we decide on the presence of rectal cancer, the next step is to find out whether it is resectable or not. So the ability to achieve clear microscopic margins or zero resection should be the aim. Can we achieve this or not? Because it is the single most important feature which will determine postoperative outcome. And that depends on the location of the tumor, the degree of local invasion, whether it's superficial or deep, the pathology of the primary tumor, which is recurred. It could be high-risk tumor, mucinous signet ring, or having high-grade features like poor differentiation. And of course, the patient's fitness to undergo the resectional surgery. So when can we not do surgical management in these? In patients who are not fit, if there's unresectable extrapelvic disease, if there is generalized peritoneal disease, liver or lung, unresectable, you might be having disease still which are resectable, which are extrapelvic, that is still amenable for surgical resection. But if unresectable, then it is a contraindication for surgical management. So this is slightly controversial, but S1 and S2, proximal sacral invasion at the level of the sacral promontory, traditionally we consider it as a contraindication. Now it has become a relative contraindication. In our regional units, we do S1, S2 resections, but the outcome is really dependent on the patient's fitness and the level of invasion. So for practical purposes, it has to be really guarded with caution that such a high sacral resection should be offered without giving thought to the quality of life which you're going to offer the patient. If the external iliac vessels are encased, then it is a contraindication. The presence of lower limb edema to lymphatic or venous obstruction, and bilateral hydronephrosis caused by ureteric obstruction. So if the ureteric obstruction causes bilateral hydronephrosis low in the pelvis, it is not a contraindication. Higher level, either in the retroperitoneal bed or para-aortic area, that it means that there is so much extra pelvic disease causing the obstruction that you will not be able to clear the disease satisfactorily. So it is not just the presence of hydronephrosis, it is the presence of the level of ureteric obstruction. And of course, if there's extensive circumferential involvement in the pelvis, we will not be able to practically clear the disease. One has to realize that about 50% of locally recurrent rectal cancers also can have metastatic disease. So, of which about half of them have resectable disease, extra pelvic. So they can still be offered pelvic surgery. If they do not have pelvic, if they have unresectable disease, as we discussed, then we shouldn't offer them surgical treatment for the recurrent rectal cancer. In this pelvic group,
Hello? Again, gone? Frozen?
I think I
Disconnected?
went offline very
Yeah,
briefly.
yeah. Now you are connected. You can share the slides, I think.
Dr. Athur, I'll request you to switch off your video. If you switch off your video, then probably your other things
Okay,
will work.
I got it.
Switch off your video. I think you can continue now.
Yeah, you
Thank
can continue now.
I am really sorry for the
No
very
problem,
choppy
no problem.
signal. So what I was saying was only about 50% of the rectal cancers can have curative resection, the recurrent ones.
No, you are
Of
talking
which
about the pelvic excitation group that was
pelvic
stopped.
excision group. Yeah,
The
that is
previous one.
that,
Yeah,
that is right. Yeah.
previous one. That Kelly group, yeah. This is important. Again frozen.
The organs are 70% R0 resection rate, which is very good. On top of that, a very good post-op mortality of 1.6% and 5-year survival R0 patients of 50%, which I think is excellent results. And it's very difficult to duplicate it. The next slide, what I was talking of when I got cut off, was that about only 50% of the patients will have curative resection, can have curative resection, of which only half will have R0, which means rest of the resections will be margin positive somewhere, either microscopic or macroscopic, because of the complexity of the procedure. So this resectability rate is improved vastly by neoadjuvant chemoradiation, or if you have it, intraoperative radiotherapy. I don't know how many units in India have intraoperative radiotherapy, but only a couple of units in the UK have intraoperative radiotherapy, offering in London and Southampton. We don't have it in Yorkshire. additional boost intraoperatively to the area which is involved, showing the invasion before doing the resection. So in neoadjuvant therapy, in patients who have not had previous radiotherapy, so who are radiotherapy naive, fall into around 30% category. And who had previous radiotherapy are around 70% of the population of recurrent rectal cancers. The issue now is re-irradiation improves R0 resection rate. But how much radiation can you give? Because there is a cumulative radiation dose toxicity. So we have to do something. We know that the repeat radiation improves outcomes, but we have to deliver it to them in a way which doesn't increase the cumulative toxicity more than G3, which means moderate toxicity is if it's G4 or So there are several ways of delivering it by hyperfractionation and using the newer modalities like carbon ion radiotherapy, proton beam, or MR-Linac. These are really specialized centers. There are some European centers. I'm sure I'm aware that there's a proton beam therapy in Chennai, which can deliver this type of radiation hyperfractionated second time, even sometimes third time to this group of patients to improve their outcome. So chemoradiotherapy improves resectability from, it is 50% increased outcome, improved outcome. So if the patient can be offered it, we must definitely offer it. And in a small study from Norway, they even noticed complete pathological response in these patients. Depending on the tumor biology, in a small subset of patients who are mismatch repair deficient and microsatellite unstable, immunotherapy stands a role. So there's pembrolizumab, nivolumab, and a few more mAbs which are now available to deliver along with or exclusively to reduce propagation in recurrent rectal cancer. So immunological profiling is now routinely done in our by the tumor pathologists. And I presume that is now the current working pattern as well in India. I'm going to only
Again frozen.
Yeah, seems so.
The technical guy is there or?
No, but it is from his side, so I don't think we will do it.
Okay.
He'll have to just log in and log out.
Yeah. Are they doing a trial version before starting this program? I mean, to the speaker. Probably
If
they
the
should have.
speakers ask for it. Otherwise, now we are all familiar with Zoom.
Nowadays,
Probably
actually, every hospital has a good bandwidth.
Yeah. Probably we should check actually. At least a day, half an hour before or something.
He's back. Let us continue. Go ahead. We can see you. So we can see your slides, Dr. Hari.
Audio is not coming.
how about now?
Yeah. Now we can hear you both. Yes, you continue.
Thank you. Thank you. Thank you. I'm very sorry about
previous slide. Previous slide. Intraoperative radiotherapy.
So
Yes.
the intraoperative radiotherapy, all I wanted to mention was it is an option to avail if you are in a center which offers it. It definitely has a role for bone and muscle fixated lesions. The smaller doses used. It is part of the guidelines for recurrent rectal cancer treatment by the European Association, which is ESTRO. So it is well ingrained into the practice, but the only thing is very limited centers doing it. And we do not have it in Yorkshire. So the simplest resections to do is those confined to the rectum or the neorectum when patient has a recurrence. When it is spread to the neighboring organs, we have to stage them properly and use expertise from associated specialties.
Do we have the slides with us?
No.
Okay.
All the need to resect bone. I'm aware of a few colleagues in Tata Memorial and various other bigger centers who do it. The morbidity is higher, the postoperative complications are higher, and the quality of life is lesser. So one has to balance the quality of life we are giving by doing mutilating surgery. But if you're in a center which can offer it, of course, you can do it. When we're doing multi-organ resection in the pelvis, for recurrent rectal cancer, even for salvage APRs after anal cancer, wide excisions, the pelvic floor has to be reconstructed. Previously, colorectal surgeons used to do it themselves, whatever flap they can do. But now, almost in all specialized units, it is the role of the plastic surgeons. Once the resection is done, they come in and they use their repertoire to close the hole, to reduce the chance of empty pelvis syndrome, and provide skin cover. I briefly mentioned about the S2-3 relative contraindication, so I don't want to revisit it. So they want only to say that the morbidity and the mortality is higher. So if you're doing such a high resection, one you really justify giving the patient that quality of life. A newer technique by Sheikh from Norwich, who's also one of our close colleagues. So they have tried subcortical sacrectomy, so just with pre-sacral involvement without the bone, just a subcortical type of sacrectomy, which apparently gives, but it's only a case series, gives a good result. Lateral recurrences are mind-boggling. The only problem with lateral recurrences are involvement of the iliac vessels, the nerve roots, autonomic nerves, and the sciatic nerve. I had some few videos to show dissection from the sciatic nerve preserving techniques, but unfortunately I'm not able to share it because of the extremely low bandwidth I'm working from today. Extremely high intraoperative complications, higher return to theatre, higher blood loss, and mortality. But there are several reasonable results. All I want to say is it is difficult to repeat and mirror the results provided by those centers because they have the expertise, the high volume, availability of various support mechanisms to fulfill. So, but one has to be aware that iliac vessels can be excised and rejoined with synthetic grafts, bypass grafts, or primary anastomosis. And published literature says there's a reasonable overall survival. Disease-free survival 45% over 4 years is unbelievably high. But repeating it in our unit is going to be very difficult. And we have our own reservations to offer ourselves, but if the patient's fit enough, we refer. En bloc resections of the pelvic organs. Again, there are several series which publish resection of the ischium, the bone, muscle obturator internis, the sacrospinous ligaments, giving again an overall survival 5 years of 35%, R0 rate of 62%. But can you see the reoperation rate due to vascular complications 25%? So 1 in 4 patients have to go back for a vascular complication. So because we are doing such mutilating operations, completely emptying the pelvic floor, and then giving the patient a stoma, the patient goes into what we call an empty pelvis syndrome, which is very common. And now current guidelines are now in place to do something to reduce it. Those maneuvers and procedures which reduce empty pelvic syndrome are aimed at filling the pelvic cavity partially, if not fully, with some kind of flap organic material to reduce the complications. So I went through some literature available so far up to 2024 regarding what is the long-term outcome of surgical management of recurrent rectal cancer. You can get a local relapse, you can get a metastatic relapse. The local clearance may be fine, but the patient may have a lung or liver metastasis 6 months, a year down the line. Overall, what I found was there's a reasonable survival of 10 to 50% in these published series, which means in patients having R0 resection, R1 or R2 resection, the survival is very low. Very obviously, because we are leaving microscopic or macroscopic tumor deposits in the pelvis. So or they develop distant metastasis. So these are really mutilating surgery, complex surgery in a group of patients with complex recurrences. One has to field a lot of judgment to give them, are we doing the right thing for them to give them the quality of life? Complications are galore, 15 to 68% published literature. The published mortality, although, is very low. I'm surprised to see this mortality very low, but this is in super select populations. Hospital length of stay is anywhere between 10 days to 30 days. ICU stay 2 days to 3 days. This can be weeks together in some of our series. These are from multiple heterogeneous data. I'm not able to combine data which is comparable because the Mayo Clinic data, I can't compare with the Japanese data because of the difference in population, difference in tumor characteristics they operate on. I can't compare the European data with the UK data itself. So one has to take these with a pinch of salt. It is very important to achieve the quality of life, and the best quality of life is giving them the R0 resection. So if you can give that, giving them reasonable comfort, do it. There are several newer patient-related outcome measure tools, what we call prompt tools, being developed by several local organizations to check what is the quality of life outcomes after these procedures. I'm not sharing the data, but we can make it a very big talk. What will you do if you can't do surgery for locally recurrent rectal cancer? We have to do something, and that something is palliative treatment. This is a huge industry now, and we can give them a lot of abeyance of their symptoms, which can be excruciating. There's a lot of discharge from the pelvis, foul smelling, obstructions. So all these symptoms can be palliated to give them the quality of life. And I think it is part of our surgical professionalism to offer this palliative care as well. So they can get irradiation for pain and bleeding. They can get stents for obstructions. Low rectal recurrences, we cannot stent because the stent will be sticking out of the anal canal, will give them a lot of urgency. Only high rectal palliative care specialist consultant, it makes our life very easy and gives the patient very good quality of life. So in summary, locally recurrent rectal cancer is a very challenging surgical condition. Fortunately, the incidence is very low now, which means that it has to be managed in specialized centers who have the professionals who can give the multidisciplinary team input, and we have to tailor the treatment to the individual patients depending on their fitness, and we have to balance the aggressive treatment to the quality of life. Thank you very much. I'll end my talk there.
You can come through video. Thank you very much, Dr. Harikrishnan, for an excellent talk on the challenging recurrent rectal cancer. And nowadays we are speaking about rectal cancer means the treatment includes, apart from curative, then quality of life, post-operative quality of life, including sphincter cervix surgeries. Over a past 3 decades, I think the quality of surgery has improved to give a better quality to the patient, I feel. And you have enlightened the present concept of treating the local recurrent rectal cancer. I think, is there any question?
Hi.
Is there any question? Yeah, please.
Yeah, it was a very good talk. Thank you. Actually, to assess the resectability of the recurrent rectal cancer, I agree, it's a big challenge. Now, the CT scan, I know probably we may assess it by doing imaging, the CT scans and MRI. And many times, the CT may be operable, but on opening the abdomen, we know whether it could be a R0 resection would be achievable or not. We feel it a bit advanced, maybe because of the previous radiotherapy-induced fibrosis, adhesions, and all. So, not very sure whether we can achieve an R0 section because all the bowel will be adherent to the rectal stump and all. So, what would be your opinion? Should we start doing surgeries in them and see whether it's resectable, or we have to,
That's a good question, Dr. Sudhir. So basically, the importance when we face rectal cancer, recurrent rectal cancer, the preoperative, the workup will involve a CT scan, MRI scan, and a PET scan. So that will determine the lateral and anteroposterior dimensions of the recurrence, which organ it involves, and we can remove any of the pelvic organs. We can completely clear that none of them are. The bladder can be removed. The last two pieces of the sacrum, the presacral fascia. But what we need to know before going in for a resection is, are we able to go beyond the level of involvement of those structures to give a R0 resection? For example, if the iliac vessels are encased on both sides, it is not possible, it is impossible to clear the recurrent tumor to give a R0 resection. So it is no point in giving a trial dissection. If you have a central recurrence in the neorectum after a TME, the TME done properly will completely obliterate the planes. We won't have any plane. So that is one of the drawbacks. The benefit of the TME is reduces the local recurrence, but if we get a local recurrence, there is no plane there.
think we again lost the connection, seems.
No, you will come back.
Able to give a clearance. So the purpose of the staging is to determine which patient has the surgical clearance.
And
I hope that answered the question.
Yeah, of course. It's very challenging. You know, we have to depend on the preoperative imaging and all.
That is right.
One thing which I want to ask you is actually, you know, in the previously irradiated cases, how good is the proton beam therapy?
So 15 to 20% reduction in 15 to 20% improvement in R0 resection for bone and muscle involvement, not for soft tissue. Because the penetration is not good for otherwise. So we can't proton beam the entire pelvis. It is targeted.
Hari.
Yeah.
Yeah. What is your thought in case? What is the dose of radiotherapy you can give if the previously there is a neoadjuvant radiotherapy chemotherapy is given? Number one. And what is, I think in your lecture, if the recurrence has occurred within a year or two, the prognosis is better, or the recurrence occurs like 4th year or 5th year after the primary surgery. So which one has shown a good outcome after the second surgery or second treatment?
The second question I will try to answer first. So the earlier the recurrence after primary surgery, it depends on why the patient has recurred, whether due to inadequate primary surgery or high risk, really aggressive, purely. Then if we redo the operation properly with good resections, they survive longer. If the cause for the early recurrence is a really aggressive, poor prognostic features in the tumor, then whatever you do, the prognosis is going to be poor. Regarding the time of recurrence, the later the tumor recurrence comes, 2nd year, 3rd year, 4th year, there is a higher chance of metastatic disease and lower chance of long-term survival.
So in your talk, I could see the age group, older age group, the prognosis is less, you say.
Poor, yeah.
But in the practice, practically what we are seeing, if a younger fellow is having a recurrence that is more aggressive, and the prognosis is very bad. Because the biological of nature of the tumor in a younger age is very aggressive when compared to the older age, what we are practically seeing in our center. Do you agree?
That's again a good point. The tumor, once we know the tumor biology for the younger patient who had recurrence, we can offer immunotherapy. The side effects of immunotherapy are really, really severe. They can have really severe immunotherapy-related side effects. So even though they get early recurrence due to an aggressive tumor, if it is DMMR or MSI high, unstable tumors, the immunotherapy, they can withstand it to improve the survival. We are not going to improve survival unmeasurably in these recurrent patients anyway. The problem with older patient is the recurrent rectal tumor is very limited. So all we can offer is the minimal of small volume surgery if we can clear. If we can't clear, they go for palliation because they may not have been fit to go have a second dose of radiotherapy or chemotherapy. And they might have had partial cycles of the previous ones because of their fitness. And regarding the dose for second radiation, anywhere between 30 to 50 gray can be given again. But to reduce the side effects, we have to hyperfractionize the dosage. So they give smaller doses more frequently I'm just oversimplifying it. I'm sure the oncologist will explain the science behind it. To deliver a larger volume, but in very small fractions, more frequently. Hyperfractionation is well known now to deliver side effects.
So what percentage of patient have MSI high in your practice?
30%.
Because we are very rarely. No, MSI high patient. 30%.
MSI high, 30%.
30% of your patients.
Yeah, 30%.
So we have less than 5% in 100 patients. You have less than 5 will have MSI high, so that we can offer immunotherapies. Very, very low. I don't know about other center. What about Dr. Sudhir?
No, we
Do
also
you often come across MSI high? Very, very rarely we are coming.
MSI high we give chemotherapy them, not always immunotherapy, but we have patients with MSI high, but with complete clearance. Immunotherapy we give them.
But percentage is like, for me, probably I would say only 5% or less than 5. Even I asked Tata people also saying less than 5% only. So 30% is very.
It depends on the population genetics.
Yeah, population. Yeah. It MSI high mean then give the immunotherapy is the treatment of choice, I would say.
There's a recurrent.
Yeah.
There is a metastatic cancer. But even otherwise, your resection specimen, MSI high is not that low because you give them adjuvant chemotherapy if the MSI is high, especially T3 and 0 and MSI high is.
Yeah, I think what Dr. Rajapani is telling is the percentage of MSI high in the.
Yeah, percentage of.
It's not that high. So we
No, even in all tumors. Because we do MSI for all patients, colon and colorectal cancers. If you take 100 patients, probably less than 5 only will have MSI high.
Okay.
That was reflecting in Tata also.
There are several techniques to detect MSI.
Yeah.
And inter-procedural variations will occur as well. I'm not sure there's continuous change in our NDT and have a protocol. After 6 months, it changes. So there's continuous flux of change which happens. So I'm not sure whether that will have an effect.
No, I don't think that is all standardized now. IHC or the ELISA. So there are two technique you can detect the MSI. So that is not a big thing. Have you done partial excision in case of even the primary? For example, forget about the recurrence. So you have a CA rectum, which is mildly infiltrating. Probably it is infiltrating the right seminal vesicle. So what is your surgical option in that case?
Just the seminal vesicle.
Yeah.
We want only on the right. If it's just one side, we excise the seminal vesicle en bloc with the thing. Only if the prostate capsule is involved. If the prostate capsule is involved. So it is because of the way the anatomy is there in the last 5 centimeters in the male pelvis. So those patients ideally should have cystoprostatectomy ileal conduit. Because over the years, we have had some patients who come back with recurrence requiring advanced surgical procedures because of trial dissection and shaving on the prostate. Seminal vesicles can be sacrificed, but it has to be really superficial involvement, even on both sides.
At the same time, actually, Dr. Harikrishnan, we do a lot of anterior accentration, cystoprostatectomy. But on the final HPR, many of these patients, the prostate invasion is not there. It's a teeth tumor. So that's a problem. We may not be able to, by imaging or during surgery, we are not able to completely rule out the invasion or precisely. So the patient goes for an over cleansing, removing the prostate. And we feel
it could be due to the desmoplastic reaction. Same thing has been reflected in MSKCG paper also. So they have done prostatectomy, but it is not infiltration, as you said. So we should take our, I think it depends upon the experience, whether it is a Desmoid reaction or on-table frozen section before going for the radical prostatectomy or cystoprostatectomy.
Frozen section is depends on the pathologist
Yes.
on the day. So, but it should be pre-planned frozen section when we're doing these kind of things, not decided on the day, because they won't have their kit ready to give us the answer accurately. So, but if it's pre-planned, then frozen section is useful.
Yeah, always we'll inform the pathologist that these are things we are going to send for frozen section in the before starting the procedure itself, so they will be ready. So, is there any question in the chat box?
Raju, I want to ask
Dr.
a few
Sharma
things.
wanted to
Yes,
speak.
yes.
Very good lecture, Dr. Harikrishnan. Learned a lot from you today. A few things I just want to ask on a wholesome basis. If a patient comes to you with recurrence, the primary staging which was done to that patient for a primary surgery, before the primary surgery, that do you think is more important, or the staging which you have just of the recurrence, the TME, the post-TME staging which you talked about? Because that was more of an anatomical staging which you showed us. Anterior, posterior, right lateral, above the reflection, below the reflection. It is the primary staging of the tumor for which the patient, or I can say, I would like to add to it that the patient had a complete neoadjuvant and then surgery with a good resection margin. That is more important, or the local recurrence where it is at the survival.
I think,
or the survival.
Yeah, more than whether one is important or not, we need to go back and look at the primary stage.
Yes, you have to
the
probably
tumor
compare
biology to
them.
see if there's anything there which is going to affect what we're going to do. What we're going to do now depends on the current invasion profile of the tumor. Number of organs is invading into, the depth of invasion, and the different compartments it's gone into, so that we can plan the compartmental accentration to that extent, whether you want to lateral, posterior, total pelvic accentration, and how to plan the reconstruction. So I think both play important roles to get information about the tumor and also plan what we need to do.
Do you try to superimpose the present MR, the recurrent patient MR with the original one, and try to look at where no radiological things like that? It only depends on where it is now, and then you go ahead with your surgery in the recurrence.
So the tumor recurrences do not follow any anatomical pattern.
Okay.
So there's no point in superimposing, but knowledge of what was the primary tumor helps us to make a decision about compartments. So we have seen so-called TME patients with the rectum intact. So we have seen, although they have had a TME somewhere, they come with a recurrence or something. We have seen that they've only had a partial TME. There's a lot of rectal stump left behind. There's a lot of mesorectal package left behind. So the tumor recurrence has started in the mesorectal and gone laterally spread outside into the sacrum, and then comes. So that gives us an idea about how it might have recurred. There are some, you can do a very good TME and you get an anastomotic recurrence due to seeding. That's, no one can help that. If it's bad luck, it'll happen.
The next question, which the clinical scenario which comes to my mind is, what do you people do with patients with complete response? You follow them up or you operate them? I'll ask beyond that, because my point of contention is that if you wait for these patients to recur or to have symptoms again, if you do not operate them, you follow them up with rectal examinations, MRs, and whatever the protocol you have. You wait for their the tumors to come back. You do not operate them. Tumors to come back, and recurrence in those patients, is it different to the primarily operated one?
Yeah, it'll be different. Slightly.
Yeah, understanding what I'm asking.
We do get complete clinical response in several patients.
Okay.
Then it goes into what we call joint decision-making process. we clearly explain to them that if we have to wait and watch, they have to comply with certain didactic, very strict follow-up measures, and the patient goes on the registry. So if the patient has mental health issues, we cannot rely on them to come back. There is no family support mechanism to offer them that support. We are not convinced that this patient will comply with the surveillance measures. Then we recommend a completion procedure if it's in their best interest. But if the patient understands and chooses to take the surveillance program, understands that there is a 30% risk of non-anatomical recurrence at some point, and they may have completion surgery, and they can have the response. The issue comes with recommending after complete response as a blanket rule. If a patient develops a complication and dies, then it will come to a question in which, was this patient offered surveillance program? If they offered surgery, if they chosen it, they would have been alive and in existence now. But because they were not offered, it is the communication and the legal record, medical legal record, then we have no justification to say that we offered it, despite we knew we offered in their best interest, we did it. But they had a serious complication, and then
I can understand that part. I can understand in an Indian scenario, probably if the sphincter can be saved, probably the surgeon will operate. If the sphincter cannot be saved, probably the surgeon will think about it. What I'm asking you is the second part of it. Do you think that there is a difference in the recurrence rates of these patients who come of a revival of the disease after a complete response? Or there is a difference between the ones where you have primarily operated because of the patient not having support, not having any person to look him after, patient is not stable, then do you think that the recurrence rates are different in these two groups of patients?
I don't think so. I don't think
so.
they should be. I don't think they should be different. If it is to
I think-
recur due to a
Yeah.
cause, either due to a surgical cause or a treatment-related cause or patient-related cause, risk factor, then the dealing with it is more or less the same.
But
So-
initially you said it is not recurrence, he called a regrowth. In this wait and watch policy, they got it is a regrowth, not the
Okay,
recurrence.
no,
Because it is
I
not
got it.
operated.
Mm.
So he said it's a regrowth.
Can I answer
No.
that?
Yes,
Yeah,
yes.
yeah.
Yeah, the thing is, there had been a lot of study on that.
Mm.
So the patient is kept on close follow-up surveillance, and if there recurs, a local recurrence is identified, and salvage surgery is done, and their survival is equivalent to the initial staging of the patient.
Okay, that is what I wanted.
Yeah.
Okay,
So that's recommended. That's why watchful waiting. It's not watchful waiting is recommended.
yes.
Only thing that there is a slight increased risk of distant metastasis in these patients if they recur. So these patients should be on chemotherapy. There is a slight increased risk of liver metastasis, lung metastasis in patients.
Yeah.
So having said that, Dr. Hari, so what is your thought on Hari? Are you there?
Yeah.
What is your thought on because since we are talking about the recurrence, what is the thought process or what is your thought on lateral lymph node dissection in the primary surgery, or what is your indication in your center? Because let's say that then now the recurrence may be one of the reason for leaving those lateral lymph nodes.
Yes.
There is two different groups. Japanese treat differently, and the Western people differently, and the Asians in between we differently.
So our practice is reasonably standardized. So if the lymph nodal package is within the mesorectal envelope, then they have the standard surgery. If the lymph node is outside the mesorectal package, which I won't clear by doing a standard TME, then they have a PET scan, and they have and then the characteristic of the lymph node on the MRI is graded. So is it due to fibrosis? Is it there is a character I cannot remember now, but there is an MRI graded.
Yes, MRI grading is there.
Regarding lymph node
For the
involvement.
lymph node status, okay.
Yeah, if the grade
Before
is high,
RT and after RT also. Before neoadjuvant and after neoadjuvant MRI, we can dictate the nature of
that
the
is
lymph
right.
node. Yeah.
So they have neoadjuvant therapy. In the repeat imaging, if the tumor disappears, if the lymph node disappears, if it's not there, then there is an option, but not still. There is an option to cautiously proceed with TME as you do usually. But there is still carries a so small chance of recurrence because a fibrotic node can regrow, but chances are very low. If the node is still present and it is not responded, they definitely TME is not adequate. They will need that lateral lymph node clearance done. And that is our practice.
So only on that side or bilateral you do? Whichever
No,
side
only
is
only on the side involved.
do you
Because
have
of the
any do you have any size criteria for like less than 7 mm, less than 5 mm after neoadjuvant CTRT? For the MRI size level is there for the lateral lymph node? If it is a 3 mm lymph node, do you still go for lateral lymph node?
if it's more than the size, the characteristic of the lymph node matters especially after neoadjuvant therapy, because almost all lymph nodes will shrink. Only about one or two rare instances in which there's no response. But the lymph node characteristics, the morphology as assessed with the MRI, it is very observer dependent, and certain radiologists are confident in saying that this is not looking right. Heterogeneous, certain characteristics are demonstrated to suggest that that is highly intact. It has been correlated to postoperative histology, and there's a reasonable correlation. They cannot be 100% right, but the patient gets an additional procedure, increasing their morbidity and complication rate for the sake of getting extra clearance. But if there is an unresponsive lymph node, we recommend.
So what percent of local rectal recurrence cancer is coming in your center after the surgery? What percentage? Probably. Any idea?
Ballpark, it's around 3%, 3% over 10 years.
Okay, good. So you follow the patient up to 10 years also, or only 5 years?
No, all patients are followed for 5 years.
After that, every year they will be coming,
And
or only
until the age of 80, the other patients are under the screening program.
or they'll go with the screening program directly.
So automatically they'll be followed by another department does the follow-up. They get biannual fit test, and then they'll be offered a colonoscopy. So I get patient report back saying you operated on this 8 years ago. Now they've had some investigation. Now they found something. Can you review? So they find their way back to us.
Oh, right.
How closely you follow up them? What are your the imaging protocol?
Imaging protocol.
Yeah,
so in our unit, the first year is 3-month clinical and CEA, 3 monthly first year. At the end of first year, they get CT scan and colonoscopy. Second year is 6 monthly clinical and CEA. And then the year 3 and year 4 are yearly CEA and clinical. They only get the second colonoscopy in year 5 and CT scan in year 5. So this is now in my center in this current last 10 years. And we have a reasonable follow-up rate of maybe thousands of patients under this follow-up. I have worked when I was a trainee 20 years ago in certain units in East Anglia. We did yearly colonoscopy and CT scan. So they've compared, because of available data. It's actually good to have different practice because there is a data pool to compare. So one set of data to the other. They have not picked up more recurrences. But the patients have had colonoscopies and CT scans, extra radiation, extra cost and everything.
Yes, agree. Even there is a controversy on that. It's still a debatable issue whether any patient need a follow-up at all, because it's not very cost effective to find out a small percentage of the patient who has a recurrence and to treat them. So
the reason to stagger it like that is the highest recurrences of one second year is 6 months, and then a CT and a colonoscopy is dropped there right in the middle at month 12. So it won't be exactly month 12, it will be between 12 and 15 months. So it will be in the first 2 years they get a colonoscopy and CT.
Is there any question in the chat box? Is Dr. Deboshi, who is looking at the chat box?
There is no questions on the chat box. Probably in that follow-up, we add an ultrasound every 3 months because it's readily available in our place. So we always add an ultrasound to it.
we also do an ultrasound
for the liver.
Yeah, ultrasound liver and fluid.
Okay.
So it's a non-invasive. It's good for pickup. Of course,
And
CE and ultrasound. Yes.
You can really treat them if there is a liver metastasis and detected. We also do 6-monthly ultrasound scan.
Yeah, many of the liver metastases are operable.
Yeah.
So in this recurrent, I skimmed through the slide, but in the recurrent series, we have had cases of
oligometastasis, you said, yeah.
concomitant pelvic clearance and liver resection, pelvic clearance and lung resection if they are fit to do it. It is if you're doing a 12-hour pelvic exentration, then that is meaningless. It's not recommended. But if there's a central recurrence with the liver met, which is operable, then that's possible, feasible to do.
Okay, thank you.
Thank you,
Dr. Hari, for the nice presentation. Dr. Sudhir, you can talk.
Thank you for the wonderful presentation and good interactions. We could get a lot of information. Thank you very much. And thanks to everyone joining the meeting. Yes, Devoshri and Rajdeep.
I think we have to hand it over to Roshan, Rajdeep and Roshan.
Okay, Roshan
will be taking. Could we have the slide of the upcoming programs, please? Right, thank you. We have a number of upcoming programs. As you know, Amasi is busy a lot in the academic field, and a flagship program will be held at Jaipur, 30th to 31st August, the last 4 days in August. Everybody is invited to join in. It will be a complete range of technical as well as academic discussions being held over there. Next, please. Could we have the next slide, please? We have the MRC lens, which is the live operative, which is shown either a live or a deferred live videos are shown, which will talk about all the technical aspects of various procedures. Next, we have on 15th May, Dr. Parthasarathi talking about the E-TIP procedure for ventral hernias. Next, please. The next Amasi online CME in the current series would be by Dr. G.V. Rao. He's a well-known person, and he'll be talking about artificial intelligence in the gastrosciences. This will be on the 5th of June. That is the first Thursday of the next month. Next, please. The 111th Amasi skill course and FMAS examination is due to be held on the 9th to 11th of May. That's the next week at Sukhsagar Medical College Hospital, Jabalpur. Anybody in the area, please do join in. Next, please. The Amasi has started the MMAS program, the Mastery in Minimal Access Surgery. We have had one MMAS hernia already at Chennai. This will be the second edition of MMAS hernia, which will be held at Jaipur. From the 19th to 21st May would be the online component, and 23rd to 25th, the on-site or the physical meeting. This will be held at the Rajasthan International Center, Jaipur, a beautiful venue. So the links are given here. You can also find out more details at the amasi.org website. Next, please. And continuing in the MMAS series, the Mastery in Minimal Access Surgery, the next upper GI and bariatric surgery, MMAS, would be held at AIIMS, New Delhi. The online component would be on the 9th to 11th June, and the physical component would be on the 13th to 15th June. Details are available on the Amasi website. Next, please. Thank you very much for watching, and my particular thanks to all the moderators, the speaker, and also to Meryl, who contributed by supporting this program, this online CME series. This was the 29th CME, and they have supported us throughout since the beginning. Do you have anything to show, to play? Mr. Ravi?
Yes, sir. The video will be played. Nisarg, can you play the video, please? Thank you,
Sir,
sir.
it will be played.
Welcome to Merrill Endosurgery, your one-stop surgical solution empowering excellence across oncology, bariatric, thoracic, gynecology, urology, gastroenterology with innovative and reliable instruments. From precision cutting tools to advanced energy devices, we deliver comprehensive solutions for modern surgical needs, ensuring safety, efficiency, and superior patient outcomes. Introducing Mirus, range of stapling products. Powered endoscopic linear cutter. Endoscopic linear cutter. Linear stapler. Linear cutter. Circular stapler. Hemorrhoid stapler. Monic trocars. Eliaro trocars. Eliaro bladeless trocars. Mesic energy device. Mesic compact ultrasonic. Mesic ultrasonic. At Merrill, we don't just innovate, we empower. Together, let's create more to life.
Yes, we have disconnected from the online connection now. So what we discuss now will not be transmitted.